Okay, I think we're rolling. So just before we start up properly, a couple of housekeeping things. So I've got a couple of questions about the revision quiz, which usually comes out like Thursday, Friday. So our usual quiz guru, Sahil, has been sick, so we've been working around that. We'll try and get that out to you as soon as possible, and we'll try and get a week 5 one out to you as well. So just keep an eye on the Facebook group for that. We'll do our best. He's a very sick man. He's doing his best for you guys.
He's fully
Namaste.
sick.
Namaste. And also, so you guys have your ethics assignment going on at the moment. I had a few questions about that, and we're thinking of setting up a session for that, like a Q&A slash tell you a bit about like tips and advice for how to do it. So we haven't got a certain date or time for that yet, but when we do, we'll post it on the group and something like that. So keep an eye on the Facebook, and we'll bring out something related to the ethics assignment, hopefully help you guys along a little bit. With that, I'll hand it off to Kyle, I think, is our first presenter.
Yep. Lovely. All right. Let's do this. Okay. Present. And turn off video. Hide video panel. There we are. All right. Hello, everyone. Welcome to week 5 of PSPlatypus. Today we're going to be going through these topics. It's a pretty light week, aside from perhaps bones and cartilage and alcohol metabolism. But yeah, let's get on with it. All right, bones and cartilage, also known as connective tissue. So as I spoke to you, I think last week or a couple of weeks ago, there are 4 primary tissue types, 4 categories that we class tissue into. And those are connective tissue, epithelial tissue, muscle, and nervous. And epithelial we've already covered last week, as it says in my notes. And connective tissue is another one of them. And then the other 2 we're going to cover in upcoming weeks as well. So there are 3 basic components of connective tissue, and those 3 are here. We've got specialized cells, and then the 2 components of extracellular matrix, so ground substance and fibers. So connective tissue, it functions to support, connect, or separate tissues from one another, as the name might imply. It occurs everywhere except in the central nervous system, the CNS. And there are multiple different types of connective tissue, such as bones and cartilage. And the way that you get different types is depending on the proportion arrangement of the different components of connective tissue. So ground substance is, more of a gel-like fluid, and fibers are that fibrous structure. And then we have specialized cells that help create that extra and maintain that extracellular matrix. So specialized cells, they vary in shape and function. There are different types of specialized cells. And they develop from the mesoderm. So the mesoderm develops into mesenchyme or mesenchymal cells, which are stem cells. And then those differentiate into different types of specialized cells. And specialized cells' main function are to produce, so secrete, extracellular matrix. And you can see here we've got chondroblasts, osteoblasts, lipo or lipoblasts, and fibroblasts. So the blast suffix refers to the fact that they're immature, actively secreting cells. And you can see there's sort of mature or develop into the more mature forms, which are more involved in maintenance of that extracellular matrix. And you can sort of derive from the prefixes what they are, what tissue they're involved in secreting the extracellular matrix for. So chondro meaning cartilage, osteo meaning bone, lipo meaning, or adipo meaning lipid or fat, so fat tissue, and fibroblasts having to do with producing fibers, and they're the most abundant specialized cells. Extracellular matrix, so this is the real the real meat and bones of extracellular, of connective tissue. It is what really does all the connecting of the connective tissue. So that is divided into fibers and ground substance, as I've mentioned earlier. So fibers, we have 3 main types. So we have collagen, or the main collagen, and that's the most abundant type, and that's made of collagens type 1 and 2. And that's really the strong, flexible, but in terms of it can bend, but resisting of stretching collagen. It's really the strength function. Elastic fibers, those are made of elastin microfibrils, so a different underlying structure. And they really perform that elastic function. So they are able to stretch, and you can sort of see that in, say, the skin or the arteries, the external ear, things like that. And reticular fibers, so those are made of type 3 collagen, another type of collagen. And they perform a really important function in forming a delicate mesh framework. So they're sort of gently supporting cells in that extracellular matrix. So yeah, reticular fibers do that. And ground substance. So ground substance is a clear gel-like fluid that performs a variety of functions, including providing nutrients, diffusing waste, and performing mechanical support. So water is very hard to compress, right? So it means that the more ground substance you have in a connective tissue, the more resistant it will be to compression, which performs a variety of useful protective functions. And ground substance, that's made up of water predominantly, very high percentage is just water, plus some macromolecules, proteoglycans and glycoproteins. And those sort of form, so the proteoglycans are bound to something called glycosaminoglycans. You don't need to know the key detail, the details, but the general idea is that those proteoglycans are binding water. So they're sort of keeping water around them, and that's how you retain water inside the ground substance. And glycoproteins, I think, perform a slightly different function, but you don't need to know the key detail, the details of it. Okay, now in terms of classifying connective tissue. So for our purposes, blood, we consider a connective tissue that has no fibrous content. It's just sort of got its plasma and the specialized cells. Loose connective tissue. So loose connective tissue is what it sounds like. It's loose. So it has loose fibers and an abundance of ground substance. So that means that it's quite flexible and deformable. You can change the shape of loose connective tissue. And you can see that in sort of fatty tissue, breast tissue, and other reticular tissue. So calling back to those reticular fibers in terms of the 3 different sorts of fibers that we saw. And then you have dense connective tissue. So in contrast to loose connective tissue, it has lots of fibers and only a few specialized cells. And it's quite inflexible, it's strong, it's tough. Its job is to have a lot of tensile strength. So it can be sort of pulled or pushed on without breaking. So you can see that in 2 different types of our dense connective tissue. We have regular dense connective tissue, and that's when all the fibers are sort of running parallel to one another. So they're all going in straight lines, and that enables maximum tensile strength in that specific direction, right? So you can imagine in sort of our tendons and ligaments, where we're using muscles to move our bones around, we need to have those really strong connections so that those tendons and ligaments don't break, but instead transfer the force from muscle to muscle or muscle to bone. And irregular dense connective tissue, so that's where it's not in a regular orientation. They're all in sort of a crisscrossy, dense mesh-like fiber arrangement. And that maximizes strength in multiple directions. So you can see, for instance, in arterial walls, you'll get that, and that will enable the strength of the arteries in multiple directions so that they're not just tearing here and there and everywhere. On top of that, we've also got cartilage and bone, which I'll go into a little bit more detail in a moment. Okay. So in terms of histology, I've just got a few pictures here to help delineate some examples. So we've got loose connective tissue here, and I'm realizing that there are a lot of icons showing up on screen. So I'm sorry about that. I'll try and remove those. I'm not having much success. Okay, so you've got adipose tissue here that is containing a lot of fat, you can see here, and then you've got the loose extracellular matrix. It's mostly filled up with cells. We've got areolar tissue where you've got the fibers and they're running in different directions, but they're quite loose. Once again, you can see loose fibers. And then we've got, I've written articular, but I think I meant reticular. And you've got reticular tissue there. And then onto that regular and irregular dense tissue. So you can see here this sort of regular parallel orientation of fibers in this tendon. And then in this artery wall, we can see that we've got the fibers running in lots of different directions, and that's causing that multi-direction tensile strength. And you can see fibroblasts, remember those specialized cells that secrete extracellular matrix, particularly fibers, in these images, both in these pictures and in these proper images. All right. Now, onto cartilage. So cartilage does not have neurovascular supply, really. So that means that it doesn't really have blood supply and it doesn't really have nerve supply, which will be relevant when we're discussing the healing or the repair of connective tissue. Cartilage falls into three main types. So you've got hyaline cartilage, and that's the most abundant type of cartilage. And it is most abundant, and you'll find it in many places, including especially the lungs. In the ribs, you have costal cartilage, and on articular joint surfaces to reduce friction and enable that smooth gliding function as we have our bones almost touching one another. You need the cartilage to enable that smooth, seamless articulation. And so hyaline cartilage performs that function. Elastic cartilage has a lot of elastic fibers. As we were discussing earlier, those elastic fibers made up of elastin microfibrils. And you'll see that, for instance, in the external ear and in the epiglottis, so in your throat. You'll see, and that's because those specific areas need this sort of flexible function. And then fibrocartilage. So fibrocartilage is very fibrous. It has a high tensile strength. And you'll see that in places like the intervertebral discs, in the annulus fibrosus, which is basically this ring of fibrous tissue, this external ring between your vertebra, so in your spine. And then you'll also see it in your menisci in your knees, which perform a key function in the knees, keeping your knees from falling apart. And also when hyaline cartilage gets damaged all the way down to the bone, what you'll see a lot of the time is that fibrocartilage will form the scar tissue that repairs and takes place of where the hyaline cartilage was and was damaged. So the fibrocartilage performs a key function in being that scar tissue and retaining some of that function that was lost by the damaging of the hyaline cartilage. I'm seeing a lot of questions, but I'll address those probably in the comments just after, like in the chat, just after I've finished presenting my part. Okay, and now we have cartilage histology. So you can see we've got hyaline, fibro, and elastic cartilage. So different to the order that I put them in the previous slides. But what we've got here is chondrocytes, so those sort of mature cartilage cells in lacunae, which are these sort of divots, so these spaces that have been sort of worn out for the cartilage cells. And a key thing with chondrocytes and with cartilage is that since they're sort of in these lacunae or a lacuna, they can't actually really move much. So they're sort of stuck where they are, and that will be relevant in tissue repair as well, which is the final slide for me to discuss in this topic. And you can see sort of the elastic cartilage, we've got lots of elastic fibers. In fibrocartilage, it's quite fibrous as well. And in the hyaline cartilage, it's not very fibrous at all. But you can see sort of these arrangements. Chondrocytes, cartilage cells always look quite halo-like. That's a nice description for them. And you'll usually be able to, once you've looked at a few pictures of cartilage, you'll probably be able to identify if you see a histological image of cartilage, you'll be able to go, oh, there's a chondrocyte, so we must be in cartilage. Okay, and now onto bone. So bone actually, it surprised me when I first learned about it. Bone actually has a rich neurovascular supply. So it has a lot of vessels and nerves running through it, which means that the cells are most certainly living. And you can see we've got two main different types of bone. So we've got compact and trabecular bone. Trabecular is the spongy bone that is sort of has a network structure and is honeycomb-like, and we can see that sort of here. You can see that here. Sorry. There, okay. You can see that here. And then you can see the compact bone is much more compact. There's less air or less empty space, less space between the cells, the osteocytes. So compact bone, it's made up of concentric layers, as you can see in these diagrams here. And it gives the strong function. It has a lot of, it's very dense, and so, or it's more dense, and so it's got that strong protective function for the bones. Whereas trabecular bone has more of a compressible function, so it can actually be compressed a bit, and that is actually good for the bone. And it also can store bone marrow within it. And on top of that, compact bone is organized into these things called osteons. So these sort of cylinders here, and those allow these osteocytes, these bone cells, as you can see in these sort of orange parts here, it actually enables them to have contact with that neurovascular supply. And this all ties into the regenerative potential. So in terms of tissue healing, so bone can actually repair quite well due to its rich supply, whereas cartilage has only a limited potential, and that's due to its poor supply and those lacunae. So the chondrocytes are bound inside of those lacunae, so they can't really migrate to other areas where they might be needed to repair cartilage. And so often you'll get them replaced by scar tissue, perhaps that hyaline cartilage getting replaced by that fibrocartilage, which has different properties to original cartilage, but is better than, say, there just being a tear in the cartilage. But yeah, that has functional impacts on patients. All right, thank you very much. And I'll answer questions in the chat.
Alrighty, let's talk about alcohol metabolism. So, are you guys able to do that? Yep. Yeah, perfect. Okie dokie. So alcohol metabolism, this is actually a question some people asked me about, like a topic that some people asked me about. So if you want us to cover something, or like there's something you're confused about, you want us to devote a bit more time to it, and we think it's going to be a big topic, then like let us know and we will put it in. This is ultimately like a reactive curriculum, so it's going to be based on what you guys want and what will be useful to you. So feel free to ask about it. So this is a fair thing to ask about because it does come up in some of your biochem stuff. Alcohol metabolism becomes a problem not only in alcoholics, but also in acute cases where people come in and they've had alcohol poisoning or something like that. So we talk a lot about the different pathways involved and mainly how those impact on the body's metabolic processes, because there's quite a wide range of things that alcohol can actually do to you. So the main way that your body gets rid of alcohol or breaks it down is through the middle pathway. That diagram at the right looks a bit scary, but all you need to do right now is just follow the middle line. So you see ethanol, it goes through acetaldehyde, and you can see over there just on top of the little equilibrium arrow, we have ADH, that stands for alcohol dehydrogenase, which is the enzyme responsible for converting between the two. So ethanol will be converted to acetaldehyde. Acetaldehyde is actually quite toxic, so we want to then go and turn that into acetate. And acetate can actually go into the circulation, be used in other metabolic processes. But the main point is, for 90% of the time in a normal person, we go through that middle pathway there: ethanol, acetaldehyde, acetate, and using alcohol dehydrogenase. So the body will often prioritize this pathway over other things because ethanol and also acetaldehyde can be quite dangerous to it. So it wants to get rid of those because otherwise it'll cause damage to the body, and that can actually lead to neglecting some other processes. Now, another interesting thing, which I want you guys to know because it's about to become very important, is that when we go through the ethanol to acetaldehyde pathway, so using alcohol dehydrogenase to catalyze that reaction, we have a coenzyme being used, which is NAD+. Now, we are loading the coenzyme, we're converting NAD+ to NADH, but we're not unloading the coenzyme in the same reaction. So what we're doing overall as we go through this pathway is we're increasing the proportion of NADH to NAD plus. So you can see it described there in the bottom right as the NADH to NAD plus ratio. So if you guys have talked about coenzymes, you remember, happens in the Krebs cycle, glycolysis, all of those sort of things. Your body has a pretty fixed amount of coenzyme. It's just a question of whether they're existing in a loaded form or an unloaded form. So during this process, we increase the proportion of loaded coenzyme. So usually let's say you might have 50-50. If you drink a lot of alcohol, you can actually end up with then increasing the ratio to say like 75 NADH and 25 NAD plus. So that has a lot of downstream effects on your body, the fact that we have an imbalance in the ratio as compared to normal proportions. Right. So here's where we start getting to the many, many consequences of alcohol metabolism. So alcohol is quite energy rich. There's a lot of energy in ethanol. It's actually one of the highest energy food sources out there. You have carbohydrate, protein, fat, and hopefully you guys aren't eating nucleic acids, but I presume they'd be on there as well. Ethanol is higher than all of them. So there's a lot of energy in ethanol, which can be good kind of in a way. But in practice, it tends to increase your blood sugar when it's consumed, and then your body panics and says, oh no, my blood sugar is going too high, I need to maintain homeostasis. And so you're going to have insulin getting pumped out into your bloodstream, and that can actually lead to overcorrection. So you end up with lowered blood sugar because a couple of things. So first of all, you've got your insulin locking up all of your blood sugar in storage, because that's its normal function. And then you may at the same time also have the actual impetus disappearing. So the alcohol, which was the big input of energy, may go away. So you stop drinking, you're no longer getting more blood sugar in, but your body is still acting as if it's getting lots and lots of blood sugar in. And so we sort of overcorrect, we drop too far, and then we end up with hypoglycemia, so a lack of blood sugar. And of course, you guys remember when we learned about your sort of integrated tissue metabolism, blood sugar is really, really critical to certain tissues like your brain. So that can be quite bad. We also get dysregulation. So the reason we say dysregulation is because a lot of different things can happen, and they're all bad. So acetaldehyde, I mentioned how this is toxic. So both acetaldehyde and something else, you might see ROS, like an acronym in places when it comes to alcohol metabolism, and they might not explain it. What it means is reactive oxygen species. You don't need to know what it is. You just need to know that it exists in the name. So both acetaldehyde and ROSs, they can actually cause damage to your mitochondria, and that actually inhibits part of the fatty acid oxidation pathway. And so what happens there is that you are less able to break down that stuff. So you get a buildup of fatty acids. And what you'll see sometimes in the liver of people like alcoholics or people with acute alcohol poisoning, could be either of them, you'll actually see like parts of the liver will be broken down. You'll have what you would call lipid droplets. So like this is where you have so many lipids in there which can't get broken down that they actually start building up, and you have the appropriately named fatty liver. We also have fibrogenesis. So that's just sort of like the scarring of the liver. It's just getting broken down. In fact, Carl just mentioned we would get scar tissue when tissues try to build back, but they're not able to build back with the right type of cell. And so we can over time get more and more scarring in the liver and more damage. Now, we also get acute hyperlipidemia. So some bloke comes in, they've drunk, 12 standards or something after drinking 8 early in the night, and their lipid levels in their blood are really, really high. So that's probably not got to do with the liver damage, especially if, say they're not a super long-term alcoholic. So that can just be because of there's so much energy in the alcohol, like I said, which means that your liver is going to be making a lot of triglycerides, trying to store that energy in a different form. And it's going to be secreting, if we go back to our cholesterol and lipid metabolism concepts, VLDL, very low density lipoproteins. So it's going to be secreting those to go throughout the body. So you can see right here, just on this slide, how so many of the concepts you've talked about then interact with alcohol metabolism. It has really, really wide-reaching effects. A little tidbit here is that the acute hyperlipidemia stuff can actually be sort of solved a little bit by the damage to the liver. So you normally have hyperlipidemia because your liver would be making too many fatty acids, but then you can actually end up damaging your liver enough that it stops being a problem, which is mildly depressing state where you damage your body enough that your body can't damage itself more. So we don't stop there. We have more consequences. So alcohol, because remember I talked about that NADH to NAD plus ratio, that the cellular respiration, which uses NADH and NAD plus quite a bit, relies on that ratio being at a certain level or within a certain acceptable range. Now, alcohol can actually push the ratio out of that range. So we can end up having too much NADH. And of course, NADH is not super useful to cellular respiration, except at the very end. So if we're trying to break down glucose, we want NAD plus. And if we have less of that, then we're going to find it harder to undergo glucose metabolism. So you can have a lack of effective glucose metabolism, and that leads to tiredness. So some patients with alcohol poisoning, they'll actually present with tiredness when they come up to you. And there's one more, lactic acidosis. This is a pretty common symptom. And so basically what happens is, again, we're dealing with that NADH to NAD plus ratio. So we have a lot of NADH. Your body wants to turn that back to NAD plus. So see, I'm sort of ascribing agency to your body here. Really what's happening is that this is a chemical reaction, and any sort of chemical reaction is going to happen more and happen more efficiently when we have a greater abundance of the reactants. So NADH is one of the reactants when we're turning things, we're turning pyruvate into lactic acid, same diff. And so when we have a lot of that, it's a lot easier for us to form lactate. So we get increased formation of lactate, which is obviously not great for your body because lactic acid then needs to be turned into other things. Lactic acid unloads the NADH, which is good for us, but it's also acidic. And so this is going to decrease the pH of the body overall as it spreads throughout your body, and it's going to cause lactic acidosis. And of course, we're also wasting pyruvate a little bit there because, as you guys have talked about many, many times, converting pyruvate to lactate is not a super effective process. It's actually pretty inefficient compared to turning pyruvate into carbon dioxide and water, which is what we'd usually be doing in aerobic respiration. Okie dokie, this is sort of a little tidbit on the side. So there's a system that they want you to know about, which is called the microsomal ethanol oxidizing system. That's a lot of words. All you need to know is it's the bottom system there. So if you look at the diagram on the right, this is sort of a cutout of the previous one. At the bottom there, you'll see a little, there's two curved arrows, and there's CYP2E1. That is the name of an enzyme, which has an alternate pathway of ethanol breakdown. So in a normal person, like a normal non-alcoholic guy, pretty much all your alcohol is going to be metabolized through alcohol dehydrogenase. But when you have a chronic alcoholic, you can actually have increased prominence of this pathway. So it uses a different enzyme. It has slightly different reactants too. So this is a slightly different reaction which is going to be occurring. And this pathway actually uses ATP. So whereas ethanol to acetaldehyde is a little bit more neutral or even beneficial to your body in terms of energy, this one uses ATP, and this is sort of theory stage, but we think it might be why we have increased resting energy using alcoholics. So doctor, I'm tired all the time, and I drink 8 standards every night or something like that, because their body is using this pathway to get rid of all that ethanol, and it's actually using up the energy that they'd be otherwise using to do other things, basically. All right, so what happens when we get a patient who comes in with all these symptoms and we're trying to treat them? So there's a couple things that we can do. The first, probably the immediate thing, especially for a patient with acidosis, because this is basically like what it's counteracting, it raises the body pH, opposite of lowering it, counteracts the acidity. It makes your body more alkaline, which is good because we want to keep your body within an acceptable range, usually having a little bit below, if I remember correctly, 7 pH. So if you look at the diagram at the right, again, it looks very scary. It's not very scary, don't worry. So bicarbonate is HCO3. So you can see it sort of in the bottom left corner of that little square there. So the arrows show what you can convert it to. So HCO3, it dissociates into OH minus hydroxide and CO2, carbon dioxide. So the carbon dioxide is going to be removed by your lungs because your body is very good, turns out, at getting rid of carbon dioxide. The OH, on the other hand, the hydroxide, that actually bonds to H+, which is a hydrogen ion, and it forms water. So H+ is acidic, water is neutral. So if we put a lot of hydroxide into your body, it's going to take away a lot of the acid in your body. And that's basically all we're trying to do here. So you see over, this is actually comparing it to carbonic acid, which is what happens when you have too much CO2 in your body. So you can see there on the left pathway, let's say we make H2O and CO2. This could even be the products of, say, of respiration, for example. That turns into carbonic acid, and that ends up increasing the acidity of your body. So you might have heard at certain points, if we don't have enough like respiration in your lungs, if that's not efficient enough, we can actually raise the acidity of the body. So that's what's happening normally. And then if we put bicarbonate in, we can neutralize a lot of that acid. So that's why we use bicarbonate as a first-line treatment for acidosis in your body. We're actually trying to get rid of the acid, and we do that using bicarbonate. So sodium bicarbonate is just like, that's the form we find it in. If we could just put bicarbonate in, that would work fine. Thiamine. So thiamine is a little bit more conceptual. This is not as easy to understand, and you don't need to understand it as well. It's basically that when you have long-term alcoholism, it has, even beyond the metabolic effects I've talked about here, you can have damage to, say, your gut and stuff. So you're less able to absorb important nutrients, of which thiamine is one. And thiamine is quite an important one. So when we don't have enough thiamine, we can commonly have things like constipation, fatigue, heart failure, paralysis. So commonly we can have things like constipation, fatigue, and more uncommonly, in more acute and severe cases, we can have heart failure and paralysis. So obviously it's a pretty big deal if we get those. So we want to avoid that. So we give the patient thiamine. Usually they'll be like, if they have a drip for something like an IV, we'll add thiamine to that to try and counteract it. A lot of words. That's at the end of this one. So I'll check chat to see if there's any questions. Feel free to just chuck them out as well if you have any questions about alcohol metabolism. Okay, so
Alrighty.
Yep, go ahead.
Oh, no, go. I was going to move on, but if you want to answer the question.
Yeah, we got one question from Anushka. So how's the bicarbonate administered? Usually, again, through IV. So you'll give them a drip, basically. You'll add bicarbonate, and you'll give them bicarbonate, and you might add thiamine, for example. Excuse me. Why are we deficient in specifically thiamine? So the answer is you're not. You'll be, if you have, for example, a chronic alcoholic, you'll probably be deficient in a lot of vitamins. Thiamine is just a particularly important one. So of course, heart failure and paralysis can be very, very serious for us. And so because those are such big consequences, it's one of the ones that we're like particularly concerned about. And it'll vary from patient to patient. So some patients say they might have enough thiamine or they might be deficient in something else. And so we might add that instead. But thiamine is a pretty common one that we want to deal with.
Yep, I hope that answers all your questions. So moving on to learning theory, health and illness. So in this topic, we talk about sort of behavior and how it's influenced by learning and the different psychological principles surrounding learning and different theories. So it's kind of interesting. In this sort of topic, you just want to be able to understand and explain and apply the different models used, which we'll get to really quickly. So just as a beginning, what is behavior? So behavior is essentially just actions that occur in response to a situation. So in modern medicine, behavior is more and more important in maintaining the health of people. With increasing life expectancy, there's an increased prevalence of chronic illnesses, which are largely controlled by making responsible and healthy decisions. And that is something that if we can help people control, it would be very valuable. And behavior is primarily controlled a lot by learning. So this is your first learning theory that we'll talk about. It's called classical conditioning. I'm sure you guys have seen this example of like the dog salivating and in response to a different stimulus other than like the cookie or whatever. But essentially, what's going on here is that you have an unconditioned response to an unconditioned stimulus. So this is just a normal reflex that occurs when the doggo sees the food or whatever. And what we're trying to do is we're trying to associate this conditioned stimulus with a neutral stimulus until the doggo is conditioned to respond the same way to the neutral stimulus in the absence of the unconditioned stimulus. That might sound like a mouthful, but I feel like this diagram explains it like pretty well. So you have eventually this conditioned stimulus is sufficient to create this conditioned response in the absence of the thing that actually caused a response in the first place. So you can see this in things like in a lot of even clinical situations. So for example, someone experiencing nausea from the smell and flavor of seafood, that likely is due to them having flashbacks or an unconditioned, or previously having an unconditioned reflex stimulus to some event like them having salmonella for a bit, and associating that bad event with seafood, and that learning causes them to experience nausea. So yeah, that's classical conditioning. The next type is called operant conditioning. So something before we go on to this one, what's important to know is that classical conditioning occurs before the response. So before the response, it's in response to a stimulus that's conditioned. But in operant conditioning, you use the consequence or the actual response to influence future behavior. So operant conditioning occurs after the response. So operant conditioning is when you sort of provide positive reinforcement or negative reinforcement, positive punishment or negative punishment. So you see this in like everyday examples, right? So giving a child a sticker to promote eating vegetables. So you can see that play out in the sense that you're giving this child something. So when you're giving a child a sticker, that is positive because you're adding something, and you're doing that in order to promote a behavior, which is to promote eating vegetables, which is now called reinforcement. So if we look at this table and we sort of add these two words together, we call it positive reinforcement, the addition of something to promote behavior. Equally, the second example we have is removing freedom due to committing a crime. So removing freedom would be removing something which is negative, and committing a crime, and we're trying to do that to discourage behavior, which is discourage committing crimes, and that would be punishment. So that's negative, removing something, punishment, which is to discourage the behavior, so negative punishment. But yeah, it's just a 2x2 table that you can use to sort of figure out what's going on. Something to note in these sorts of questions is you want to pay close attention to the way they word it. So for example, I can say removing freedom or giving solitude. I don't know. Like you can phrase the same thing in two different ways, which changes if it's positive or negative. Yeah. But yeah, that's essentially the idea of operant conditioning. Now, there's another theory as to how behavior is influenced, and it's talking a lot more about how your behavior is influenced by other people. And I imagine you guys probably have your personal life stories that also relate to this. So it's essentially role model learning, Bandura social cognitive theory. The social part of it is when we try to imitate people that are generally viewed as competent or highly regarded. And those are the two key words. It's competent and highly regarded. And the cognitive aspect of it, of social cognitive theory, is that it's us cognitively understanding our experiences and trying to apply it through the use of role model learning. I don't know, personal anecdote. There was this really smart guy in my class, and he always moves his eyes a lot when he thinks. So like I noticed that after like 3 months of hanging out with him, I started moving my eyes a lot as well. So that's to do with him being competent, or me thinking he's competent and highly regarding him in my life. So yeah, Bandura social cognitive theory. All right, so one more thing is the concept of self-efficacy, which I want to bring across. So the behavior that we do is also influenced by our own self-belief about our own abilities as well. So I think your lecturer will go through a little bit more in detail, but there's some key differences between self-efficacy and self-esteem and stuff like that. But essentially, it's generally the sense of self-belief about your own abilities. So for example, adolescents treated for depression with a greater sense of self-efficacy to cope with the symptoms demonstrated better outcomes 2 and 4 years later. is taken straight, just ripped off from the slide that we were given. But I feel like that's a very good example about how your own perception of your own ability changes your outcomes. So what this means is if we can instill self-efficacy into our patients, we can probably improve outcomes. And another thing is that you're more likely to do things you believe you can do. That's one part, and are good at doing. That's part two. And another personal anecdote. So self-efficacy, if you identify as, for example, if you identify as an athlete and you have self-efficacy in that domain of expertise, you're more likely to stick to your own exercise and diet regime as well. But it's just behavior influenced by self-belief. And that's the end of my spiel. If you guys have any questions, check it in chat. Thanks.
Hello guys, can you see the screen?
Yep.
Great. So now we're going to talk about indigenous health. It's an interesting topic with a little bit of history. And it's actually a high yield topic. You don't just need it for your exams, you also need it as future doctor in Australia for your interactions with your patient. So first of all, who are the indigenous people? They are the people who live in the mainland before the European settlements. And how can we identify Aboriginality? It's identified by three things. First of all, the person, him or herself, need to identify themselves as indigenous people or Aboriginal or Torres Strait Islanders. Then they need to have to be of Aboriginal and Torres Strait Islander descent. And finally, they need to be accepted by the indigenous community. And like they not defined by skin color or blood. They just need to have these three things. So there is a gap in across broad range of many health indicators between indigenous people and non-indigenous people, where indigenous people are disadvantaged. This gap exists across communicable and non-communicable diseases, communicable diseases like HIV, tuberculosis, influenza, hepatitis B and C, and non-communicable diseases like diabetes, cancer, and asthma. Like, for example, end-stage kidney diseases are 7 times more common in indigenous people than non-indigenous people. Also, rheumatic heart disease, which is caused by group A stroke, are 26 times higher in indigenous people than non-indigenous people. Also, in terms of life expectancy, indigenous males have lower life expectancy than non-indigenous males by 11.5 years. Also, indigenous females have lower life expectancy by 9.7 years than non-indigenous females, which is a lot. Now we're going to talk about the causes of this gap. What caused this gap to happen in indigenous health? We have 4 causes. First of all, displacement or colonization, which starts from 1788 to 1837, which means stripping indigenous people out of their land and positions. And this has caused because of the introduction of new diseases, like there were diseases that indigenous population didn't know before, because they were separated from the outer world. And so when the Europeans came, they introduced new diseases to the indigenous community. Also lots of sexual diseases due to the sex abuse. Then we have physical displacement. They were moving from their properties, their places they were living. Also, there was an introduction of addictive substances like drugs and alcohol that the indigenous community wasn't familiar with before. And lastly, frontier violence, which is basically means violence and massacres that cause the death of indigenous people. Then we have segregation, which started from 1837 to 1937. Like the numbers of indigenous people were dropped dramatically due to the displacement, the massacres, and when the Europeans noticed that, they forced the indigenous community into settlements and missions to, as they call it, die out peacefully. And this caused the loss of freedom because they were put into settlements forcefully. This also caused separation of family. Children were separated from their families. And lastly, third control over property names. They were not allowed to have indigenous names. They have to be English names. Also, they were forced to speak English, and basically they were forced to change their culture to be Europeans. Then we have the forced assimilation. Like in 1937, there was a conference for indigenous welfare, and this conference, the aim of this conference was to force indigenous people to become like non-indigenous, like Europeans. And then one of the strategies they made is called breeding out the black, or dilute the indigenous blood, which means indigenous people were forced to marry non-indigenous people, and then their children again forced to marry non-indigenous people, so that their indigenous blood will dilute. And that's why we said the indigenous status isn't identified by blood. Also, the stolen generations, which means that the indigenous children were taken from their families at the age of 6. Lastly, the structural discrimination from the 1960s until our time, which means disadvantaging indigenous people systematically by cultural blindness. And cultural blindness means that people think that their culture is the normal one and not recognizing the other cultures. And institutional racism. So these are the determinants of indigenous health. Like basically, the previous 4 causes are the causes of these causes. So social determinants, like they have lower incomes, low rates of education, racism, family violence. Then behavioral determinants, they have higher rates of alcohol consumption, poor nutrition, substance abuse. Also physical determinants, they live in rural areas, oftentimes poor housing quality. So now we're going to talk about the solutions of this problem. The first solution we have is what we call cultural safety, which is the application of knowledge of indigenous values, principles, and norms to to overcome the imbalances of places, people, and policies, and this can be achieved by a number of ways. For example, provision of training in indigenous health, increase the numbers of indigenous healthcare workers, engage with family and community leaders of indigenous community, and engage with healthcare workers. Lastly, addressing social inequities. We have to address and admit that there is a problem with social inequity in order to overcome it or in order to solve it. So such key areas such as education, living condition, access to high quality food, and access to health services. And that's it. Thank you so much. If anyone have any question, I'm happy to answer.
Thanks, Marwan. I was just going to make a brief addendum. I only learned this from a faculty member, I think randomly mentioned it last year. And I had a bit of a read up on it. So apparently, well, not apparently, but so ATSI, Aboriginal Torres Strait Islander, as an acronym, is actually discouraged. And this is something that is very important for us to be learning, as always. But yeah, I was chatting with James, and he said, "Oh, I didn't know that either." So it's a good thing to learn. So Indigenous status is the preferred term, and that will be relevant in talking about your histories whenever you're ascertaining Indigenous status as part of your introduction and things. So yeah, there's a link, I'll pop it in the chat, of the Australian Bureau of Statistics explaining why they don't use ATSI anymore. But yeah, I just thought I'd add it on as a note. Yeah, it's considered offensive by some Indigenous peoples. So yeah, all right.
Yeah. Thank you so much, Carl. I'm so sorry, I'll change it right now.
No worries. Thank you. Thank you, everyone, for listening to that. Thanks.
No worries. So important thing to remember there. Now, our next topic is going to be about stress and mind-body medicine. You guys can see that. So this is another HEP topic, Health Enhancement Program. This is Craig Hassard with his mindfulness stuff, which will be coming up right after this. But for the moment, we're talking about why we need it in the first place. So the impacts of stress. So we're very used to thinking of stress as a sort of purely psychological thing, like, oh no, you're stressed out. There's, it's impacting your mental health or something like that. But not only does stress have psychological impacts, it actually has very profound physiological impacts. So your actual body, your actual functioning on a chemical level can very much be impacted by stress. And so that's part of why it's so important to talk about these things and talk about controlling them, because it can have real physiological benefits. So first we need to define a few terms. So stress is best summed up as a perceived inability to cope. So you've got some challenge in front of you and you don't think you can deal with it. And that's what causes stress. So if you're stressing at a test, it's because on some level, you're worried about whether or not you'll be able to pass it or something like that. If you're a driving test or something coming up, you're worried that you might forget something, or you might be inattentive or make a mistake, that sort of thing. And so this is a quite a widely used term in society. So it's broadened beyond that main definition into a lot of things. So you can talk about you're stressed out because you just feel tense about something. You might not even be that worried. You might be called stressed out because you're depressed or something like that. So in wider society, it has a very broad usage. We also have anxiety. So anxiety is specifically when we're talking about a future event. So it's not something happening now. You can very much be stressed while you're doing a test or something, but you can't really be anxious while you're doing it, at least using the definition that we use in Met. So the other important part of anxiety is that it's disabling. So it stops you from being able to respond appropriately. So it's not actually necessarily a good thing then. And it's disproportionate to the actual threat. So if it was proportionate, that would just be a normal response. So like stress or something like that. And the combination of these two topics really makes it a potentially dangerous response. So what we talk about here is that we need to understand, again, that big wide variety of real physiological effects. So this is verbatim from Craig Hassard's slides. I don't believe they've been changed in several years. So when it comes to like the symptoms, the things that will actually pop up on the surface, people can feel more tired, they can get headaches, sweatiness, nausea. When it comes to behavior, you can have basically issues with controlling yourself is the easiest way to sum those up. You can have effects on immunity. This will be a really common refrain. So with a lot of things related to stress, you get immune depression, where your immune system is worse able to deal with basically infections and other things that come at it. It's just not up to scratch. And we also have, in terms of disease, it acts as a risk factor. So if you are already at risk of developing cancer, heart disease, something like that, we can have a much higher risk of that and much higher risk of a severe disease when we have stress. And we also have effects on genetic expression. So this is sometimes called epigenetics. And this is basically, we'll talk a little bit more about this later. I'll explain a little bit about how it works. You don't need to know too much about the mechanism, just the fact that it does affect genetic expression. All right, so let's talk about the fight or flight response. You've probably heard about this, just in popular culture, it's pretty well known. And it's basically a wide variety of reactions. So it's not just one thing. We have to talk about a whole bunch of different combined physiological reactions to some sort of danger usually. So the classic example is, your ancient human on the plains running from some, big predator, or at least seeing a predator and needing to decide, are you going to fight or are you going to run away? So we don't talk so much about that actual decision. That might be more to do with medicine of the mind and psychiatry. We're basically involved in the physiological response. So we have something called the autonomic nervous system. I don't know how much you guys have done regarding the nervous system, but the general idea is we've got a few different divisions. One of the biggest divisions is called the autonomic nervous system. So this is basically your nervous system does a lot of work without you realizing it. So at any point, you're breathing, you're digesting food, your heart is beating. There's a lot of stuff going in your body, which you don't directly control. Of course, you can be on manual breathing and that sort of thing. But in normal, hopefully I haven't put any of you on that. In normal life, all of this stuff is going to happen unconsciously, but it still needs something to control it. So just because you aren't thinking about it doesn't mean it doesn't need control. And the autonomic nervous system is what's responsible for it. So all of that stuff there is going to be regulated by the ANS in normal life. Now, when it comes to these sort of situations, we have a further distinction which becomes important. So within the ANS, that's a big umbrella, we have two parts called the sympathetic and the parasympathetic. So the sympathetic nervous system is responsible for the fight or flight response. This is when there's danger, some impending threat. This is going to put you on high alert. Now, the parasympathetic nervous system is basically when everything's fine. So this is the chill part of the ANS, and we call it the rest or digest. So when you're resting or when you're digesting food because everything's safe and you don't need to worry about anything, this is what's dominant. So the next slide shows sort of the effects of them, and you can see right here, in a lot of cases, the effects of the parasympathetic and the sympathetic nervous system are directly in opposition. So the parasympathetic will do something, so the sympathetic system will do the opposite. And you can sort of think about it again, using that example, you see a predator on the plains, you can sort of go down the chain and think, okay, well, what will the ancient human body want to do to protect itself? And as you go down and you think of the effects on each organ, it'll pretty much line up with what you think. So you dilate pupils, makes your eyes, gives you better eyesight, makes it easier for you to see danger, inhibits saliva production because you're not eating right now, you might be running away or you might be fighting. Dilates your bronchia, so it gets more air into your lungs because you might need more air again to run or fight. Rise the heart rate because you're going to have more physical activity. It's going to actually inhibit your digestive organs because, again, you don't want to be digesting stuff. That's going to use up energy that you need right now. And at the same time, you jacks up your adrenaline production, which is, how we helps us ignore pain, helps us move faster, helps us think faster. And that's obviously what you need in that case. And then it again has reproductive effects further down the line. Those aren't so much linked to the main response. That's more just a case of additional unconscious functions. So again, you can see how all of these work together, and we have two sort of states of being. So the one state in which everything is fine, and you want to focus on, nutrition, things like that. You want to focus on actually resting, basically resting and digest. Hey. Whereas in the sympathetic response, this is when you're on high alert. This is when there's danger and you need to do something about it. All right, so stress is not always a bad thing. So it's not like, oh no, there's some stress in my life, I'm gone. It's when we have a normal response to danger, that can be good to you, because as we talked about it, it helps you it helps you think more clearly, it helps you act more, it helps you undergo more action when that's important, that sort of thing. So it can actually be quite good. So the problems happen when either it gets triggered by something which it shouldn't get triggered by. So, there's some sort of thing which is not actually a direct risk to you, but is nevertheless causing stress to you. That's not a good thing. Or when we have prolonged stress. So a normal stress response is brief, because again, you can think of right back to the the evolutionary origins of a fight or flight response. This is when there's danger. So you want it to happen. You want to get away from the danger, get rid of it somehow. You fight or you flee. And then you want to stop because you're not in danger anymore. You want to go back to that resting and digesting state because you want to spend as much time there as possible. That's what actually allows you to sort of thrive. So you want to spend as little time as possible in the fight or flight response and having that sympathetic nervous system activation. So we can have different negative consequences based on what's going wrong. So inappropriate activation. So this is an acute thing. So what happens in the acute level? Well, we can have increased risk of cardiac problems. So we see in the working population, this is probably the thing that clinches it. In the population that goes to work on Monday mornings, we get a spike in heart attacks on Monday mornings because of the increased stress. So obviously on an individual level, the risk increase might not be that big. So this might not have a huge effect. But when you look at a whole population, you can see a measurable effect on cardiac issues of stress. This is a real thing and it has real impacts on your patient. And when it comes to chronic activation, we have, I'm going to bring up on the next slide, we have a really big variation of different things that can happen. It's a very wide ranging thing. So we have a concept here called allostatic load, which is just sort of a catch-all term for the increased strain pressure in your body when you have a lot of stress. So again, immune dysregulation is really common. So, it's harder for you to deal with infections. And of course, we also have inflammation. So inflammation is another thing that comes up with stress. You will often have what we call chronic inflammation. So inflammation, you guys probably know about if you did 3-4 bio, if you did the bio-bridging course, you might remember from that. We'll talk about it when we go through immunity. Point is, it's a response which does a lot of weird stuff to the tissue where it's around, increased blood flow, permeability, all of that sort of stuff. That's okay as long as we're using it to fight an infection. So it's okay as long as it's a temporary thing. It's not okay when we have a permanent thing happening. So it's not good long-term for these cells in your body to be under a constant state of inflammation. It's meant to be a temporary state. And so ideally, we actually get rid of that as soon as we can. And allostatic load, when we have a high amount of stress, we can actually have chronic inflammation, which is not good at all. Atherosclerosis, central obesity, again linked to dysregulation of your metabolism. Hypertension, high blood pressure, osteoporosis, we can get degradation of various parts of your body. Atrophy of brain neurons can lead to neurodegenerative diseases like Alzheimer's, dementia, that sort of thing. And we can have, again, epigenetics. So we can have little effects on your genes and little, although it might not affect the genes themselves, it can affect sort of associated molecules and that sort of thing, which affects how genes are expressed. As you learn more about genetics, you understand more there. You don't need to know, you don't need to know too much about it, just that it exists and it's a real thing. We can also have allergic activities and more irritation there. And I don't know how many of Craig Casler's lectures you've watched. If you've watched a fair bit of them, you'll know that he cares a lot about telomeres. Telomeres are sort of a marker of aging. They're bits of junk DNA at the end of your chromosomes. And so the shorter they get, the more errors you have in things like replication and the more accumulated problems you have. So this shortens telomere. You will get a comment about whether something shortens or lengthens or keeps telomeres the same in almost any slide of Craig acids. So this one shortens telomeres. Basically, anything bad shortens telomeres, anything good lengthens or keeps them the same. Yeah, so these are some specific diseases. So these are things, if you look at the slides, is things you'll see there are certain things which are specifically linked to stress. So we have this very broad category, and then we also have some research into stress, which just shows us that certain things are like intimately linked to it, or which we can definitely say there's a link here. So there are a few examples there. Now, the other thing, again, with all of these concepts, we want to understand that they don't exist in isolation. So we can get a positive feedback loop in some cases. So you have chronic inflammation because of stress, which increases your risk of stress because you have chronic inflammation, which is a stressful condition to have, which increases the risk of chronic inflammation because you're under stress, which causes chronic inflammation. And then you go around and around and around, and your stress gets worse and your chronic inflammation gets worse. And you're in sort of a spiral because those things are feeding back into one another. You're in a positive feedback loop, and that is really bad. And so that can, not only that, but other bits of individual parts of this response can feed into one another. So it's very much an interactive problem. And at the same time, so there's good news here, because even though despite the fact that we have psychological factors, which can make you can have detrimental impacts on the body. So your psychological stress can have negative physiological impacts. You can also have positive effects on your body. So you have your social connection and positive experiences. We have research which links it to better immunity and worse and better inflammation responses. So not only can psychological health impact your body negatively, it can actually impact your body positively. It works both ways. All right. Now, the last thing I'd like to clear up is the two concepts of well-being, which we talk about in the context of HEP. So we have the first one, which is hedonic well-being. So this is like when you pleasure seeking, what feels good, and then you go after that and you pursue that. So this has positive mood effects because, of course, it feels good. You feel happy. You're pursuing that sort of thing. But we have linkages to inflammation. So that's basically a code word or a clue that it might have negative health impacts. There's the same sort of effects that we saw with stress, that sort of thing. Now, eudaimonic well-being. So this is where you get well-being because you feel like you're doing something important, or you feel like you're engaging with the people around you, or you have some sort of purpose in life. And so that has both positive immune effects and positive effects on immunity and other sort of physiological stuff. So the general idea here is that we have two types of well-being. Both of them have some positive effects. One of them has a downside as well. So I guess the lesson is sort of stay in school, pursue eudaimonic philosophical type of well-being as opposed to pleasure seeking, which is a weird message to have in a medical lecture, but there you go. This is what the research suggests, basically. All right. With that, I'll hand it off to Kyle. If you have any questions, unmute and throw them out now, or feel free to throw them in chat and we'll answer them a bit later.
Yeah, and so that ties quite nicely into mindfulness. So it might seem a bit woo-woo, but mindfulness is actually pretty experience. I'm imagining I've gone quite robot-y for a second. Oh dear. For some reason everything's crashing. That's good. I might get James to talk through it if
Wait, God.
so I think
Oh.
I just disappeared and returned. I might James, could you screen share and I'll talk through it?
Yeah,
This is revision, so he's one of the people who studied medicine.
Rachel, you're unmuted, just so you know.
Yeah, okay, I'll screen share. Give me a sec.
Lovely, thanks, James.
No worries.
But yeah, in terms of personal anecdotes, so inspired by Deepak's beautiful personal anecdote earlier on.
So.
Yeah, I think mindfulness can be really effective. I found it substantially reducing my stress. I had about a 40-day streak of doing like 5 to 10 minutes of mindfulness meditation each day, getting sort of near the end of year exam period last year. I was like, all right, let's give it a shot, feeling a bit stressed. And it really legitimately, I think helped me better manage my stress and sort of check in with myself at the end of every day and just go, all right, I'm still alive, I'm still breathing. In reality, I've got stuff mostly under control and it's all going to be okay. Anyway, on with the slides. Thank you, James. Yeah, so something that Hesed talks about is the default and online brain and factors that contribute to inattention. And really, I think the key thing to understand here is the idea that our default brain, what we are at a normal state, is actually quite inattentive. We aren't present. We're not really focusing on the moment in day-to-day life. And online, the online brain is a manifestation of this. So it contributes to, you can imagine you've got a notification, or you start thinking about watching that Netflix show, or what is your favorite YouTuber? Have they uploaded something recently? Things like that will sort of pull you away from maybe the task at hand, or just experiencing the present moment. And of course, it's perfectly fine to be intentional in your enjoyment, in your responsible hedonic pleasure-seeking pastimes. But in terms of your long-term well-being, if you're constantly inattentive and distracted and not present, well, that can have pretty adverse effects on your well-being. As you can see, default brain is sort of associated with things like stress, anxiety, depression, ADHD, autism, schizophrenia, Alzheimer's, and generally reduced performance, which may be relevant to some of you who are attending PSPs. Good on you. Also a key concept is, so the attentive mode is sort of the counterpoint to that. So it's when we're focusing on something, we're in a flow state. Probably, perhaps once in a while, you might have found that in an exam or something like that, you might be zoned in because you've only got so much time to do it and you've just got to focus. And that's very efficient, very effective. And that ties into multitasking. So multitasking as a concept, there's a lot of evidence that shows that it doesn't really exist. So really, when you're multitasking, you're switching your attention between one task and another, or between multiple tasks very rapidly. But each of those switches actually reduces your efficiency and can have some pretty significant impacts on you actually getting work done efficiently. So yeah, it's not efficient. Try unitasking, or focusing on a single task at a time instead. Next slide, please, James. I like this. I like having someone else to click the slides for. All right. It leaves my hands more free, and I like to talk with my hands. So mindfulness, that's the key concept here. So the Google dictionary definition is the idea of focusing on the present moment, or it's the state of focusing on the present moment, and while calmly acknowledging and accepting your feelings, thoughts, and bodily sensations. So the way that you develop mindfulness is through training your attention and attitude. So your attention is what you focus on. So that could be, the work that you're doing, the studying that you're doing, or if you're meditating, it could be your breath. So a specific feature of your breath, your inhales and exhales, and how that makes your nose feel or something, or your bodily sensations, which ties into that. And your attitude is how you practice, how you feel about the things, the thoughts that inevitably enter your mind, and the distractions that occur. And you've really got to approach that with these sort of 4 impressions or perspectives. And those are self-compassion, openness, curiosity, and acceptance. So you have to be kind to yourself and willing to sort of acknowledge and explore what has entered your mind before being willing to let it go and return to the task at hand. And there are 3 main types of practice, ways that you can develop your mindfulness. And those are, so you've got formal practice, and so that's attention training, that's mindfulness meditation, the bread and butter of mindfulness. You have informal practice. So that's, for instance, perhaps every time that you walk through a door or sit down or something, focusing on your breath a bit. And that will help you ground yourself in the present moment. And then you have cognitive practices. So these are sort of these more specific and sort of discrete practices that you might do in terms of perception. So acknowledging the things that you're perceiving, focusing on the things that you are perceiving in the present moment, letting go. So not being overly attached to any specific thought or thing that is entering your mind, and accepting it, acknowledging it, but then allowing it to pass. And presence of mind. So that's all about being in the present moment. Next slide, please, James. And yeah, here's some stuff that these are the selling points of mindfulness. So there are a bunch of benefits. You can see I've got telomeres bolded there. So it slows the degradation of telomeres. It increases your emotional quotient or your emotional intelligence. It improves your performance, both physically and academically. It reduces your neuroticism, which is tied to things like anxiety and stress. It reduces mood disturbances, things like that. And a key statistic that is probably one of the few statistics that is worth, or that a lot of people tend to memorize for exams, is that 78% of people in a specific study relapsed into depression without having practiced mindfulness, whereas only 36%, so the intervention group, only 36% relapsed into depression. So that's pretty compelling, right? There's significant evidence that practicing mindfulness helps you better manage your stresses, and that might consequently impact on things like depression and anxiety. But I've just got generally mindfulness benefits things. Like there will be certain things where perhaps they might put in a question that would, maybe they're talking about a cancer that isn't breast cancer, and maybe mindfulness doesn't have any evidence supporting its use in that. But for instance, breast cancer is indicated as actually being improved. I'm not sure if it's outcomes or prognosis, but yeah, mindfulness has been shown to have a positive impact on patients with breast cancer. But yeah, I strongly support and encourage you to try out some mindfulness. There's a Smiling Mind app that I think was developed by Monash. It's free and just guides you through some meditations, and I found it a useful way to manage some stress. And the final slide, please, James. What might be a little bit more relevant or compelling to us, yeah, are these clinical benefits of mindfulness. So patients practicing mindfulness have experienced things such as reducing chronic pain and fatigue, and improving function, sleep, mood, and depressive symptoms, as we were talking about earlier. And doctors practicing mindfulness, and this is a very important thing, is being present and encouraging yourself to be in the present moment. It reduces the likelihood that you're going to misdiagnose a patient. It increases your emotional quotient, so your ability to interface, interact, and communicate with patients. And it also reduces your stress, which is a very significant thing because of the rates of depression, suicide, and just generally burnout among junior doctors, medical students, things like that. It's very important to take care of your mental health, and mindfulness is a nice way to be sort of preventive with that. All right, thank you very much. Thank you for watching and listening and enjoying the discussion of telomeres. Any questions? Take it away, James.
No worries, that pretty much brings us to close. So stick around if you have any questions. Feel free to post them to us either over voice or in the chat. Other than that, like I said, keep an eye out for both. We'll try and get those quizzes out for you, and we'll also be coming up with something relating to your ethics assignment in the next couple of weeks, hopefully. Keep an eye out for those. Thanks for coming today. Have an awesome day, and I'll see you guys not next week because that's mid-sem break, but in 2 weeks' time.
Yep. See you guys later.
Thank you.
Legends.
Thank you.
Thank you, guys.
Bye.